First, we're going to kick it off this morning with the most central question, which is the value of continuous comprehensive primary care to the health of individuals and communities. And I am really pleased to welcome back to moderate this discussion, Dr. Ishani Ganguli from Harvard, well-known publisher, researcher, and an incredible moderator and discusser of the issue of primary care. So with that, Ishani, I will turn it to you.
It's wonderful to be here again in the National Press Club with all of you in person and virtually. I'll introduce myself briefly, and then I'll let my colleagues introduce themselves as well. I'm Ishani Ganguli. I'm an associate professor of medicine at Harvard Medical School, a practicing general internist primary care physician, as well as a health services researcher focused on primary care payment and delivery. I also have the honor of serving on the standing committee for primary care from NASM, and we've just had a really great public meeting over the last 2 days that you'll hear more about later this week, or later today, I should say. I'm going to hand it off to Dr. Bazemore for his introduction as well.
Thank you, Ishani, and Brady, and Sean. It's great to be here. I'm Andrew Bazemore. I'm a family physician, and I have several roles with the American Board of Family Medicine, a senior vice president for research and policy, a co-director of a center that's just up the street from us, the Center for Professionalism and Value in Healthcare, and oversight of a number of leadership and scholarship programs for the next generation of primary care. And I also get to practice with a wonderful group, a residency program about 20 miles from here in Virginia, the VCU and UVA affiliated Fairfax Family Practice Centers.
Hi, I'm Brady Steineck. I'm a family physician. I also serve as the CEO of Community Healthcare. We are in Canton and Akron area in Northeast Ohio, and we are a value-based care oriented business. We have been in existence for almost 40 years. We are currently in full risk payment models across the entire book of business on our Medicare side, and we are partnered with Agilon Health, who's a national company that helps us perform and do well in that space, and just really happy to be here.
Thanks so much. So I'm going to set the scene a bit for this morning's conversation, but also for the next 2 days. So primary care is the foundation of the U.S. healthcare system and more broadly, right? And we have this really strong body of evidence which would tell us that primary care leads to better outcomes. That includes better patient process outcomes, it includes better patient experience, lower use of low-value care, less use of high acuity care like ED visits and hospitalizations. We also know that primary care is associated with lower mortality when you look at robust studies looking at counties across the country. And these benefits seem to be predicated on 4 core functions of primary care that Barbara Starfield really made famous. And those are first contact access, that your primary care doctor is your person that you go to, your doctor or team is the first person you turn to when you have a problem. The idea of comprehensive care, so when you're reaching out to your primary care team, that you are really getting everything that you need in that setting, and holistic whole body care. There's the idea of continuity of care, which we've traditionally defined as interpersonal continuity, that you have this longitudinal trusting relationship with your doctor and team, and that goes in both directions. You trust your doctor, they trust you. And finally, coordination of care across different clinicians and different settings. And so today we're going to be focusing on the idea of continuity specifically, and we'll have almost an hour to go really deep on this topic. And I wanted to turn to Andrew next to lay out the evidence for us. What specifically do we understand about interpersonal continuity and its benefits?
Thank you again. Let's see if I've got this on. Okay. Thank you again, and for leading particularly with the why. We're in an age where all the conversations seem to be about how to get more value in a U.S. healthcare system that has over doubled its per capita GDP spending on healthcare relative to its nearest neighbor, while continuing to underachieve and even seeing things like mortality and life expectancy going backwards. And what Barbara Starfield laid out for the first time, interestingly, in a large academic health center setting, was whether you were looking at the county level all the way up to multinational comparisons, that those systems that really focused on primary care infrastructure were easily able to demonstrate better health outcomes, so quality. She was able to demonstrate links to mortality and longevity, obviously patient experience. And in laying out those 4 C's, I think it may be out of the 4 easiest to say that continuity has the biggest mountain of evidence. We started looking at this as we were beginning to imagine, how we might measure continuity in a value-based purchasing environment, and we thought we better go back to the literature. And we worked not only through Barbara Starfield's literature, but looking with John Saltz, who had written an article in 2005 that said from 1962 to 2002, what do articles say about continuity in a measurable fashion, really specifically linking up the outcomes we care about? And in his world, that was excellent patient experience reports. That was things like not going to the hospital or the ER when you didn't need to. That was total costs. That was even specifics of cost. And if you look at his article, it is a mountain of literature that is almost universally favorable to these continuous trusting relationships. We updated that with John and published it just last year, looking at everything that's been published since 2002. And I guess not surprisingly, even though we were challenged by some external advisors to say, well, the health system has changed a lot. Technology has changed us. People are moving away from traditional senses of continuity. Maybe the literature's changed as well, and it really hadn't. We were looking across, again, ER utilization, hospital total cost generally, patient experience, and it's almost a universally positive literature. The worst things we were finding, and you know this well from health services research, how hard it is first to measure certain things and demonstrate associations, were the occasional neutral study, where it didn't say continuity didn't have a positive benefit. It was just hard to detect the relationship. So surprising to me, actually, given what we know of how hard it is to prove anything in the world, how easy it is to show how these continuous trusting relationships line up with better value in healthcare. So.
Well said. So I want to take a moment to think about how our primary care landscape is evolving and changing in good and bad ways, right? So we know that a lot more PCPs are leaving the workforce. Many of us, and I'm partly to blame, are becoming more and more part-time, right? There's doctors who practice a few sessions a week, and that's become much more common over time. And there's also, we'll spend some time today and tomorrow talking about new private sector entrants into primary care, which are just expanding the set of options that primary care doctors have. That patients have, I should say. Some of these include retail clinics where they may be offering certain primary care services that are more discrete, right? So not a primary care relationship, but you're able to get your antibiotic at a minute clinic, as for one example. So in that context, I wondered if we could think a little bit about what happens to continuity as patients have these increasing options. Maybe there's less access to their own traditional primary care doctor. And what is that sort of trade-off between access and continuity? And we could think about, like, is it truly a tension and a trade-off? Are there ways to allow for both? And what's needed to make sure that we still maintain continuity and access in this evolving environment?
Do you want me to go first?
Maybe Brady, and then you'll.
Yeah, great. I think you bring up multiple points there that are really key points right now in the journey of primary care. And if you're really going to do primary care correctly, you want to be the source for all of those things. Being in an at-risk model, we are responsible for our patients' experience across the entire continuity of care across the entire system. And so we want them to realize, we want patients to know that we want to be there for them. We don't want them to go somewhere where a stranger is taking care of them. We want to be the one that they call. And most of what we've done over the last few years has been just trying to increase access. That's one of our biggest challenges, again, in a workforce that is both decreasing in the number of physicians and in the hours that they work. So our strategy has really been to build teams, engaging with nurse practitioners, engaging with RNs as care managers, really looking at utilizing telehealth and technology, not as a way to fragment the system, but as a way to bring patients back in. And so for us, it's even using AI tools that engage with patients and do care management for us. And it's looking at ways, when you really talk to patients, yes, maybe that 22-year-old that's in college wanted to go to the minute clinic as a way of being quicker. But most patients, when you ask them who they want to see when they get sick, it's us.
Yeah.
And so we have to rise to that challenge. If we're going to really affect the waste in the system, like you're talking about, where you're going to have multiple duplicative tests for a sore throat, multiple visits at, where someone didn't know the allergies of the patient at the minute clinic and now prescribed the wrong medication, and now we're dealing with the consequences. If we're really going to address that quality and that duplication, we have to be the ones that provide that, and that's the challenge as primary care. We can't rely on or even want our patients to get out of the environment that we provide. We have to enhance it. And so for us, it's really fighting back against all of that. There's been a lot of headlines too about a lot of these big corporate clinics actually pulling out of primary care. And I think it's because it's so much more transactional and it's not relational. And people are looking at us for that relationship. I think in primary care, one of my mentors said an amazing quote that I'll never forget. He said, primary care is nothing more than creating a strong enough relationship to help people with behavior change. And that's what people want. The transaction part of it is sometimes more convenient for little things, but the relationship at the end of the day is really the most valuable part.
Brady, can I ask you a follow-up question? So in your group of clinicians, do you have part-time docs, and how do you... Yeah, and
over half of our physicians, I brag about this because our performance is really good. We were the #1 performer in the Agilon network last year. Over half of our doctors are female part-time moms that we love to give that option to. And we tell them, we want to be the place that you can perform the medicine that you love to do, still have the balance with your life that you want to have, and we can surround you with the tools to still do great patient care. I think we all feel this tug of, I want to do better for my patients, but I also am a human being. And in our world of so many different responsibilities for people, we want to be able to provide that. Even a lot of our male docs, younger ones, older ones, ones that are going towards retirement, we find them extending their careers because we're able to provide them a little bit more flexibility. Telehealth has done that. So I think for us, it's trying to figure out what the right balance is for building big enough teams to take care of the complexity of our patient panel while at the same time leading to physician satisfaction. We just had an NPS survey go out that Agilon did for us, and our particular company was in the world-class range because I think we're helping people practice more like they did when they went to med school. We'll get into more payment and comp structures, but we pay our docs capitated. They aren't getting paid to churn visits. So now they're able to think more holistically for their patient panel and think about what resources patients need, and they're not worried about seeing 25 visits a day and giving poor care. So I think it's marrying comp structure, organizational management structure, and the entire, every part of your business has to be geared toward patient quality and care and physician satisfaction.
Brady really said that beautifully from frontline experience, and I think really he hammered home the answer to your question. It's an and. Starfield, in writing about what continuity meant, didn't say it's continuity or first contact. And when she and Jeannie Haggerty wrote about this relational longitudinal continuity, they absolutely highlighted that this is a permanent tension. And then came the patient-centered medical home, which appropriately said in a patient-centered age, access, digital access, asynchronous access, holistic, person care depends on making sure that we meet the patient and the community where their needs are. The problem we've run into when you compound that with a real workforce shortage and what's become an obvious access crisis, particularly in this last 2 years, is there's a tendency to lose the and say all that really matters is the access. And the virtue is in 4 C's. It's a holistic paradigm. You have to pull them together, and there are ways to do that.
Yeah.
There's nothing more frustrating, and as a male part-time clinician, I'm utterly dependent on my team to maintain real continuity in a patient-centered framework. There's nothing more frustrating in a practice that is finding visits harder to come by for the patients that we have these relationships with, to nonetheless look to my right, realize that in an open slot, because of a system-level absence of thinking about that and, I'm seeing my partner's patient who's got a 3 to 6 month backlog, and that patient wants nothing more than to see them and not me. And I'm less efficient. I'm highly likely to not understand some crucial things nor enjoy the trust that allows best possible patient outcomes to happen. So that and's crucial, and I love that you brought up new models and approaches that can help us solve that. One of the most promising features I see in not just the consolidation, but some of the corporatization that does tend to get associated with moving away from 4Cs are the efforts to shrink panel size, to build these teams and invest in the partners that we need in modern primary care to really keep up with our phones and the fact that we can manage some of our patients' needs asynchronously and help direct excellent teams to do it on our behalf. I spent 9 years with a single MA, and the most fragmenting moment in the continuity and the trust I enjoy with my patients was her husband's redeployment to San Diego for wonderful Navy service. But my patient said, this is a break in the teamlet.
That's right.
And that is a crucial element of continuity in 2024. So.
I was going to respond to one thing you said as well. I think for us, realizing that keeping patients, even if it's not with their true PCP, at least keeping them within our organization is the next best thing. And we acknowledge to our patients when we have to do that, look, we get that you want to see your primary doc. They're on vacation or whatever the thing is, and at least this doc has your record, whereas someone else might not, and we can talk about continuity of information as well, which is a huge issue, but at least there's continuity within our group, and we, geographically, we're able to sometimes move patients between sites as well, and again, it's the next best and than it is an or, so, it's, sometimes you have to work with that.
Yeah. So thinking about this tension between access and continuity, the other idea that comes to mind is that we want to bring it back to the patients, right? And empower our patients to make those decisions at times as well. When it could be that you're calling for a visit and the front desk team offers them either, you can see your doctor and that'll be a couple of days wait, or you can see someone else on the team. And patients are really savvy enough to be able to make those decisions, and we don't always give them that credit. Another recent story was about a week or two ago. I got a message from one of my patients who had gone to a local urgent care. She had probably viral infection and had a couple of days of cough and wanted to get seen. Totally fine. Goes to this urgent care, gets a chest x-ray, which is clear, gets 2 antibiotics and a steroid, and then messages me through the patient portal to say, hey, doc, I went there and this is the information I have about it, this is details of the visit, and this is what they told me to do, what do you think I should do? So it was this beautiful moment where, first of all, I didn't love the decisions made there, but she trusted me and knew me enough and had the technology and the access to me through the patient portal to be able to check on that question, and she had her needs met, and that she had somebody who could listen to her lungs and reassure her in that moment when she wanted to seek care. So there may be some ways around that sort of tension is using that technology and having other ways to reach out to the team.
We just did we just changed something in our practice. We actually, instead of giving out personal emails of our staff to the patients, we created a site-specific email address for each office for patients only. And so we had a patient yesterday that called in with a rash. I had 2 providers out, totally swamped, and I said, can you email me a picture? Mm-hmm. And he was able to maintain continuity. You can't always make decisions based on pictures, but I was able to at that minute. And so I think you're totally on point about the technology. You can still create connection.
Yeah. I think acknowledging there's even trade-offs there with how do we make sure that those workloads are manageable for PCPs and teams, thinking about burnout. But it's really, really promising. I want to turn us back to this idea that we've touched on before of teams. So historically, when we've measured continuity of care, it's been at the individual level. So what is the share of visits in a given year, for example, or the dispersion of visits across individual doctors or patients have seen in office visits. We've now expanded that definition both in research but also conceptually to think about primary care teams, and you've both alluded to this. I want to talk a little bit about what does that mean in your, Brady, especially in your clinical setting, and how do we think about teams as sort of the unit of continuity that's most relevant going forward?
I'll make a brief comment. I really do want to hear Brady's much more robust frontline experience. I think first framing, back to your tension, what we're aiming for against what's really feasible in an access crisis in an evolving world where there's so many factors that push clinicians to burnout. There's no doubt that the evidence shows if you can get to individual one-on-one relationships, you probably generate the highest level of benefit from continuity. Nested, again, within these teamlets and teams, nested within practice, nested within institution. There's even some pretty good demonstrations that continuity matters not only in primary care, but when you have continuity, you can get to coordination, you can get to other functions when there's some continuity across your specialty relationships, your hospital relationships too. But back to that individual unit, that's the hardest thing to achieve in an access crisis and in a modern world where we have so many pressures. But I did want to start there and say, so what you're always trying to get to is as much individual one-on-one interpersonal continuity as you can, and you're the beneficiary of the longitudinal administrative record continuity because you nest in these increasingly robust and IT-supported systems. And at least, what we're seeing in design think is how do you build out teams and not cross that critical breaking point where they lose interpersonal continuity. But I'd love to hear what's happening in Brady.
Yeah, so with us in Northeast Ohio, just recruiting a new doc isn't always the easiest thing. And so over 20 years ago, we started hiring nurse practitioners. And even now, a lot the typical model when someone brings in an NP is that they become like the urgent care of the primary care practice. It's just overflow. Whatever can't go on the doctor's schedule, and there's no discrimination on what type of visit or what type of patient the NP sees. And it can be really frustrating because if that NP isn't as well trained or comfortable with acute care or certain chronic conditions, they're going to come back to the doc anyway. And now everyone's frustrated. And so a lot of the NPs we hired at the beginning had a lot of backgrounds in chronic disease management, diabetic education, things like that. And so we started to flip the model and say, okay, the chest pain is better suited for the doctor's schedule. And the A1C of 9 that needs to sit down for a half hour and go over their diet needs to maybe sit with the NP. And so we switched it. We actually fill our NP's schedules with chronic and preventative care, Medicare wellness visits, preventative pediatric visits, so that our physicians have acute access. Again, going back to the access point. And when you talk about continuity with one person, we did have to kind of train our patients to think differently as well. And we did that with personal warm handoffs. So in my practice, I would actually bring the NP in the room and say, Mrs. Smith, this is Amy. She works with me every day. We talk about patients all the time. And I think you need a little more time next time because we need to talk about your diabetes a little more in depth. It's not where we want it to be. And we're changing medications. So I want you to spend about a half hour with her and she's going to tell me how it went. And I've almost never had a patient say no to that when you show that trust. And it's funny because in my practice, we've been blessed with, and across our company, blessed with some amazing NPs that a lot of times once the patient sees them, they don't come back to me much. And they almost feel embarrassed by it. I'll be out on the nurse's station on my computer and this patient's getting roomed and they almost kind of like hide from me like, oh crap, there he is. I feel like I cheated on him or something. And I have to tell them, no, that's okay. That's what we want. If you like them and they're doing great, great. You have my permission. And talk about panel size. We've been able to increase the size of our panel and therefore take better care of the community in a shortage crisis that we're in an access crisis because we've opened up the teams. We added another layer with the Agilon relationship, doing RN care managers in every office. So now we have an extra layer for the patients that are the high utilizers, very chronically ill, high risk. And the continuity with those RNs now is pretty amazing as well. They're the ones doing phone calls weekly or stopping by the home to look at pill bottles. We've found so many medication errors in that stance. Just being able to add trusted team members and try to maintain that continuity and show the patient that we're all together working for you, with you, it builds that continuity and allows the team to function better and give you better outcomes.
Brady, can you talk a bit more about how you make the time and the space for those conversations behind the scenes? So various members of the team are seeing patients. How do you then reconnect and make sure that you have the same information? How do you then sort of...
Yeah, so we actually don't give our docs a mandate on how they're supposed to structure their team communication. With me, I'm blessed like you to have an MA that's been with me 7 years. And my patients know her sometimes just as much or more than they know me. And so the RN is down, it's a physical proximity thing. The MPs are flanking me at my station. My care manager is down, can hear us around the corner, and my MA is sitting in front of me. So for me, it's a very organic, daily, all-day conversation. They're grabbing me to take me in a room. I'm grabbing them. Look at this EKG. Tell me about this blood pressure. It's all day, every day. It's team. But there's other groups in our practice that do formal huddles. We'll do a huddle. They'll do it before every day or every half day. We also do a lot of panel management things where we'll sit down at lunch and go over the list of patients that are with the care manager right now and say, does this patient still need care management? Do they need PAL care? Do they need home health? Or have they gotten to the point where they're about as good as they're going to be, and we can actually maybe take the training wheels off so that it gives us more access to go after the next person that needs us? So we're always trying to evaluate as a population, as a panel, what those patients need. And so it can look different, and we allow it to be organic with our teams so that they can kind of mold it to their own schedule and their own personalities.
You know, and I want to come work with Brady as well, but you know, in our practice, and I'm very proud of the way that we have experimented with teams over time, and I want to get to some of the threats to continuity in the teams, which is so important to the interpersonal continuity with your patients in a moment. It is an act of integrating technology and asynchronous, I would call them weapons for continuity.
Yeah.
I mean, good weapons. The ability to now have in the morning, first chat that sits in my chat, walking in and logging on, is the behavioral health team saying, good morning. Well, good morning, right back at you. If you have any needs today, I am part of your, and there are 3 of them, team for the day. And I can asynchronously, sitting in the room with a patient who have identified as having an actionable mental health need or behavioral health need, make sure that my team member is aware and is able to come down the hall and pick up immediately at the end of my visit in addressing that need. I can do the same with, again, to some degree, lab and other members of our team that do things that I don't do. I would say technology has also allowed us to begin experimenting. We are not quite caught up in the AI revolution with artificial intelligence-derived responses to our, again, our patients, which so many systems are taking on, but that becomes a member of your team. Your kiosk, your portal become extenders, and getting a facile, continuous relationship with team members who know how to, since they're always going to have different approaches, even within a system that tries to maintain unity across teams, to doing things for your patients is so important. And the threat, and this is what I've at least seen in our practice, is with constant underfinancing of primary care, we lose team members very quickly to other settings. And I mean excellent folks who say, the greatest joy of my life was working in your setting, but I can, for my family, double my income working elsewhere. Yeah. We lose continuity with teams because in our environment, shifting payment relationships and value-based payment mean that at one point we had money for care management. This most recent behavioral health integration is basically because we've had a surge of a certain type of financing. Yeah. There are periods we've had it, there are periods we haven't had it. So I can't emphasize enough how important it is for us to move to not only greater investment in primary care, but things like partial capitation that really allow the flexibility to build out these critical team members and the digital structures that you've heard Brady talk about, and it is so fragile. I feel as though we're constantly inventing and reinventing continuity of teams, which permits the broader continuity that we need.
Yeah, well said. I'm struck also by something Brady said about the importance of physical space and how you construct that space to promote teams. So reflecting on my own, I've practiced in 2 primary care clinics in my career, and the first one was designed with this in mind, and we're fortunate to have the ability to do this design de novo. And we had this open space where there was an open area in the middle, almost like a nurse's station in the hospital setting, and there were teamlets where I would sit with the medical assistant that I was working with, and we had full view of the offices or the exam rooms around us, and we had those those tags that came out to show who was in the room, and we could talk to each other very readily between visits, and there's that good communication, and then sort of see what was happening around. And we had a flow manager who could sort of manage all of that. In my current practice, which is also same excellent intentions, very much oriented in the same way to team-based care, we happen to be in this setting where it's just these long hallways, and I spend so much time running around trying to find people, and each room where we have computers is just small. It's, there's 3 computers per room, so I'm often, if I'm precepting, I'm often not in the same room as the residents I'm working with. The MA is in a different place entirely. And so just that physical space can make such a difference. And as we're thinking prospectively about designing primary care of the future, really needs to look like, to support those kinds of models. I want to go back to this idea of technology. We've touched on it over this conversation, and ways in which technology may disrupt but also benefit continuity. I'll give one example and then turn it over to the two of you. So we've done some work on this idea of direct scheduling, and there's different terms for it. It's the idea of patients being able to go online and schedule their own appointments without calling in or speaking to somebody. And it's funny because in every other industry, that's just normal, right? In current state, you go to Uber or Grubhub or whatever it is, and you're able to just directly access what you want. Getting a haircut, whatever. But in our world, it's taken a lot longer to make that happen. The major EHR vendors like Epic, which is what we happen to use, has that capability. So it's increasingly used across the country, and yet we've been pretty slow to adopt it. So a few years back, a academic health center in our area adopted that across 17 practices, and we looked at the adoption and impact of that. And one really interesting finding was that visits, we're looking at the visit level, that were directly scheduled, 95% of them were with the patient's own PCP, in contrast to 70% of visits that were scheduled through the usual manner, which is by calling the office. Now, there's a couple of reasons. The main one being the technology forcing mechanism. So when you go online, you have to pick someone you've seen before. But that's a forcing mechanism that can be replicated, right? This idea that let's try to get you in with the person who knows you best, whether that's the NP or PA on your team or your doctor. And it also speaks to maybe some other sort of considerations that the front desk is making, like, you want to be seen sooner or whatever else. But it goes back to this idea of putting it back in the patient's hands and using technology to facilitate that and potentially increase continuity of care. So that's one example. I would love to turn it to the two of you. What do you see as the challenges or the maybe potential threats to continuity introduced by technology, but also the opportunities?
Sure. We actually tried the open scheduling several years ago.
Oh, yeah.
And our EHR also has that capability, and we piloted it with a couple different docs, and it ended up, for us at least, the appointment length and the complaint to match the time was not able to be done because there was no human looking at it to say, wow, that doesn't need a 30-minute visit, it's a sore throat. And so we were finding that our schedule became much more inefficient, and if those, we were also, in an access problem trying to get people in, and people in desperation to get the patient in that they had on the phone would take the online schedule block, and it just became a mess. And so we've actually come away from that and gone back to traditional scheduling now, but they can reach out to us in many different ways now. It used to be telephone only, and that's, of course, the least efficient way. So we have multiple portals now. We actually are piloting an AI that actually interfaces both with patients and with providers. So it's almost acting like a care manager for chronic conditions. It's asking them what their blood pressure is. It's asking diabetics what their sugars are and reporting back if it's abnormal, taking a lot of our care managers' day-to-day tasks off their plate. It's also a great personal assistant for us to say, hey, I just saw this patient for a COPD exacerbation, check on them tomorrow. Well, then it's texting the patient tomorrow to say, how are you feeling today? And so when you say using continuity as different parts of the team, now it's thinking differently that this technology is one of our team members. And it's all about creating more access and more relationship. And we talk a lot at Agilon about touch points. There's so much data on the more you're able to touch your patients, especially the high risk, the more times that they're interfacing with you, the better the outcomes. Well, there comes a point where we can't do it anymore with human capabilities. We have to be able to leverage some of this. And so we're trying to figure out what the next step of that is.
I think you've already pointed out it's so easy to imagine technology being a facilitator of continuity despite the tensions you've mentioned in the access crisis. And push features and algorithm design and development in an age where, similar to Brady, our patients can schedule through their smartphones, their laptops, the telephone, in person before they leave. I would add to that, before they even walk out of the room. The real problem I think we run into is not whether technology can enhance scheduling continuity, and frankly, continuity in many ways. Telehealth and the telehealth revolution of the last 4 years, it's amazing to me to watch it recede, because at least during that period, I would not wish for pandemic again, but there was a sweet spot where for my patient with acute wellness and chronic needs, I could parse continuity into telehealth visits, telephonic visits, electronic asynchronous communications, and then really strong in-person meetings. Yeah. That would seem to be what a system and a patient and a clinician team would want. I think the problem is getting back to commitment to the and.
Yeah.
The problem you mentioned, working now within a larger health system that is trying to build in very unified processes, which I understand for scheduling, and with a real hegemony of open access, is ignoring the opportunity to make sure that both the technology and the training say, let's work to get this person back to the individual, and if not the individual, the teamlet, and if not that, then at least within the same practice setting. Yeah. We have open access. We're open 6 days a week, in the evenings, have been for over a dozen years. We embrace now on multiple floors in our building different tiers of care. We do Medicare wellness visits in team-based fashion where I'm not involved until the end and then the sign-off. We live in an age where technology should be enforcing the and really, to me, Ishani, that means we've got to go up to a payer and system level commitment to the end. Mm-hmm. Because unless there's a force, a measured force that says we value this thing that clearly shows value to the health system that we're talking about today, continuity, right. If we're not measuring that and differentiating the three of us based on how well we do at enforcing, and it's not enforcing at the expense of patient centeredness, but enforcing the idea of the and. We want continuity and access. We have too many things going on in the day to pay attention to already. So do those who are scheduling. So do those who design our systems. And it kind of breaks down. And I really do think that's the key, is we've got to measure it. We've got to pay differently for it. We got to value it in our culture. And that's the only way that technology will work for us and for integration and move away from fragmentation. It's just too easy to fragment, and it's far harder to enforce the continuity.
Yeah,
so.
Well said. Yeah, I think that makes me want to go to another important topic that of measurement, right? So Andrew, you and I have worked together on this a bit, and we've also worked separately on this idea of how do you measure continuity and like to demonstrate outcomes. Historically, it's been measured, again, using office visits, sort of the traditional building block of primary care. Some work I'm doing now, we'll see how that goes, I'll keep you posted, is trying to expand that definition to include telemedicine and to look more broadly at how all these different modalities of care and continuity in that context can influence outcomes. But what are your thoughts, and I know you've been really active in this area, on thinking about measurement and continuity as a metric, as something that we should be, a goal that we should have in quality alongside other measurements of patient outcomes?
So the first thought is, of all the measures of positive functions of primary care, getting close to something that we might call continuity is probably the easiest. Mm-hmm. But it's also only getting close to what Starfield or anyone else who's talked about continuity really means. We're not measuring in a series of simple calculations. Most of them are basic numerator denominator. All right, how many total touches? It could be telehealth, it could be real visits. Did the patient have either with the system, with the institution, with the practice, or the clinician? And then we divide, and how many went to the person or the team? Right. There's a lot of ways to do it. Those are pretty easy calculations. They're not really capturing whether there's a trusting, ongoing relationship or the good things that we want to happen, comprehensive care, always first contact and coordinated, but they're at least a first step. And I will say that it's those simple measurements that have proven good enough by proxy, because they're the ones that are used in most of these studies that relate continuity back to better cost outcomes, utilization outcomes, patient experience outcomes. So I think we have a pretty good set of measures. Then we just have to figure out how to make sure, and I am in a measurement space, I suspect as you are, with profound skepticism about measurement generally. We want to improve it because it drives us crazy when it's not done well. Then we have to really figure out how not to harm through the measurement.
Right.
I'm part-time. I have great sympathy for anyone who says, boy, if you're going to measure me on continuity and I'm only there a part of the time, you've got to figure out how to incorporate these team dimensions and the other things I'm doing. I think that's achievable. Yeah. You've got to help me understand how not to penalize someone who does not have system control. My answer to that, work with system and individual level measures simultaneously. You've got to help me figure out, is this a balancing measure or is this the only thing?
Right.
Probably best as a balancing measure. But all of these in the measurement space are achievable. That'd be my answer.
Yeah. And I think it also begs the question of what's the right level of team, right? So I think it's hard, we'd be hard pressed to argue that, there's communication across an entire health system. That there is some more sort of coordination, hopefully, in that context or in that unit than let's say if somebody's getting care in a number of different health systems. But that is not a team using an organizational scientist definition, right? So where do you make that cutoff for measurement purposes, but also functionally in your practice is the hard question, I think.
And we're just getting to that edge of implementation, all of its problems. I think most folks would agree if you're going to measure some of these features, like continuity, the goal is not to penalize everybody but the top performers. It's to try to say, let's avoid the bottom first and then slowly move our way up.
Yeah.
So start to reward anyone who's above a fairly, at least minimum definition of continuity in one of these proxy measures, work at system, at practice, at individual levels, and then let's as the ships all start to rise, as most measurement science say they eventually do, when you put an incentive out there and you target it, you can come in pretty low at first and then work your way up. I think that's the way to get folks on board and trusting the measurement science there.
The other key question that you alluded to is this, when we think about this as a quality metric, is how much sort of power or influence do those clinicians have over it, right? So there's the element of, being part-time, but there's also, patients have the right and an opportunity to get care in different settings. And there's only so much influence, I think, in general, we have in primary care to influence care overall. And so that will be another challenge to as we think about this in a more formal sense.
How do we get the payer and the delivery agent at the system level and the practice and the clinician all thinking about continuity?
Yeah.
Until you do all those things, it's really hard to pin it all back on the clinician.
Yeah. Let's turn next to payment. So I think my bias is that payment reform is probably at the center. Payment is at the center of so much else that we talk about in how we organize primary care and health systems in a broader sense. I want to talk a little bit about how payment can hinder or enable continuity specifically. So historically, we've been in a fee-for-service system. We're moving towards value-based payment. Brady, I want to hear you talk about that a bit in your practice. Let's think about this for a bit.
Yeah, so I think we're looking at both at the payer level and at the physician comp level. Payment has to be able to, like you just said, has to encourage the behaviors that you want. In a fee-for-service model, when you're trying to actually perform continuity, you're trying to improve the outcomes of your patients. That is totally against what a fee-for-service model is encouraging. A fee-for-service model says do more widgets, see more visits, don't worry about quality. And a lot of us that were in that model, you look in yourself in the mirror and say, I'm not doing as good a quality as I could. And you've got this little pit in your stomach sometimes. And you have to be able to, if you're looking for value, you have to then incentivize that with the comp structure. We're able to be at full risk across Medicare Advantage and traditional Medicare in the ACO REACH model right now. And what we've done is, once the payment comes into our company, we've created an artificial capitation system for our physicians. So across the entire Medicare line of business, they're paid a full cap with $0 for E&M codes. And so why do we do that? Well, we don't want them churning visits. I don't want to bring in the 40-year-old with a UTI that she knows it's a UTI. She's had it before. Guidelines say I don't need to see her. I can treat her. But in the past, in a fee-for-service world, I want to code a 99212 or 213 for that. Well, but then the problem is my heart failure patient that can't breathe just went to the ER because they were told there's no access. So we have to be able to align the resources with the need. So that's what capitation does. It allows me to think of my panel as a whole. What are my finite resources, my time, my physical space, and my staff? I need to be able to allocate those valuable, high-cost things. The overhead is high in primary care. I need to be able to allocate those things to the people that need it the most. So even my chronic care now, I'm lengthening out visits. I'm not seeing them in the office as often. I'm using a blend of the team, of telehealth, of phone calls, because I need that space for access. And I wouldn't be able to do that if I wasn't comfortable enough knowing that I got paid on the first of the month. And that's the reality.
Yeah.
And so I have to be able to match the comp structure to the outcome that I want.
Brady, some of that was a deliberate choice in the face of, and please flesh this out for me, but a minority of your patients are in let's say, MA risk-sharing arrangements. So you had to say, even though it's not all of your patients who are in these risk arrangements, in fact, it's a minority, you had to make this deliberate shift to value-based payment in how you pay your doctors. Can you talk a bit about what that?
Yeah, so we still collect fee-for-service for the commercial population. That's the reality. However, I think now you're getting into the next layer, and really it should be the first thing we talk about, and that is your mission and your culture. And for us to look at our mission statement and say, we're here for the patient, we're here to take care of the community, and just because a patient is in a different comp structure or insurance model doesn't mean that I treat them differently. And so we're treating all of our patients this way. Because think about it, I live in rural, suburban Northeast Ohio where there are more patients than we can take care of. So even if I'm not getting that fee-for-service, my schedule's full every day. And so for me, even to take care of all of those fee-for-service patients, I've got to be doing population in panel management, and our docs haven't seen comp go down from that because, again, we're still full every day. And so for us, it's about telling people, look, whether we're getting fee-for-service for this patient or we're fully capped for this patient, why are you here? Do you want to practice medicine the way that you went to med school to practice it? Do you want to be able to do what's right for people without having to look in the mirror and say, I did that because of the payment model? And so it comes down to that big lift on leadership as well.
Boy, that was an excellent mouthful. Back to your question about where this idea of measuring continuity fits in a larger landscape of measurement, and also some real skepticism about being nibbled to death by ducks with all the measures that we're seeing. I do think that you have to look at continuity as one of those high-level, very limited number of measures, at least according to Starfield and most of the evidence, that you can imagine being a balance across, again, a far wider range of values that we're being judged on in value-based payment. And it's almost absent, at least to our awareness, in any measurement structure that we know of. It has to be integrated. It's definitely a high-level measure to be, accommodated, not at the expense of some of the quality measures we've come to value, but it's got to be one of a small number of functional measures that, again, works across from system down to clinician, works across building the culture that I know both our trainees and our current clinician teams want, and that the patient is very much demonstrated. In any patient experience measure that I'm aware of, there's something that gets close to trust and continuity and links those two together. Yeah. I think that you've got to just wade in and add this to the milieu, and then accept that it's not going to be perfect, and also accept that it's going to, like every other measure, it's going to come with some who score above and some who score below a certain threshold, and you jump into it like any other implementation science. You start to figure out how does this balance against the things that we have. But there's no doubt about it in my mind. It's easy to measure. It's easy to measure at multiple levels, and it's time to pull it into those practices. So
when you talk about measurement and picking a benchmark and consistently measuring people, I think the next part of that we've found really helps is transparency. And we do have a forum every month where we put all of our providers in one room and have a meeting. And that's a great time to actually go ahead and put the data up on the wall. And if there's one thing I've learned in my career, it's that doctors don't like to be less than average. And so when we put those numbers up on whether it's cost of care, ER utilization, any kind of continuity measure you're talking about, or even quality metrics, the ones at the bottom of the list are the ones coming to us. We're not having to go to them and say, you need to be better at this. They're coming to us saying, how do I get better at this? And so that's where then you can help somebody.
And I think Brady would agree with me here. If you look at behavioral economics and popularized in books like Nudge, we're really just trying to set up a system to allow us to do the things that we're intrinsically motivated to do. And I have not met in primary care, and I won't just say primary care, boy, in behavioral health, this is abundantly true as well, anyone who devalues continuous trusting relationships. That is one of the draws to the profession. And it's the draw in return from the patient side. Even in an age where we've been questioning whether, there's something different about this generation, they don't value continuity. Completely disagree.
Yeah.
There are different ways of achieving it.
Yes.
There are different levels of need, and the older and sicker we get, the more we immediately see the value of it. But there's no denying that most of the patients and most of the clinicians and team members in primary care want this. We just have to set up the measurement structure to create that intrinsic nudge.
Brings up an important issue around the future of primary care and trainees, right? You mentioned this is one of the big joys of our practice, that we get to have these relationships with patients. We've all experienced this. It's one of the aspects of primary care that's hardest to impart on trainees, just because of the nature of the time they have and the structure of traditional primary care training programs, or any kind of training program. I wonder if we could speak a bit to that idea. So what are ways that we can capture and help trainees experience the joys of continuity in primary care in a way that will just be one other reason to choose it? Because as we all also know, that we have a lot of challenges in keeping our trainees in this field.
Yeah, I think we have to change the system to longitudinal. At least the med schools that are in our geography that we actually accept students from and try to help. It's very episodic. And a month at a time here or there, or a half day here or there. And if we're able to start creating partnerships with both independent groups, systems, and the schools to get people in to the same setting, hopefully with some of the same patients throughout their med school experience, and then also in residency. I mean, even in residency clinics, there can be a lot of discontinuity based on coverage and whatnot. I think there has to be a lot more intentionality around it, because when you talk about the recruiting crisis of primary care, everyone wants to do a specialty. They're missing out on the number one, like you said, one of the most rewarding thing. And so it's not only going to be a way to train them better, but a way to also get people to want to do it more and address the shortage.
I love the way you refer to training not just as graduate medical education. We've really fragmented undergraduate medical education to a point that it doesn't surprise me we're struggling to get clinicians into primary care, not just for longitudinal payment in a sense that there's a shrinking scope, but we're losing the relational aspects that really drive primary care interest. And so looking to models, I left to visit the University of Houston, was fascinated that they've not only adopted team-based approaches to training, longitudinality in their clinical exposures. So it's not preclinical and then clinical, it's throughout, but even household level continuity. I have a family that I am identifying as mine and me theirs from day one that I have to graduate with and help them walk through a 4-year journey. And returning and restoring that you and me level of understanding in an increasingly fragmented system, that this relational continuity, which almost any student who experiences it says, wow, that's what I wanted. That's what I came for, at least those who go into primary care. Putting that in UME is important. And then in graduate medical education, we keep saying it, burnout happens in residency. I mean, it's very real and at a high number. We have to frame, number one, how continuity in the relationships make the visit unit easier.
Yeah.
There's nothing more frustrating than discontinuity of care. It adds more time to the visit with lower outcomes and lower satisfaction on both sides. That's one. And then two, hey, if we're going to measure on this and we're going to try to encourage a culture of continuity, it's not going to be at the cost of more pajama time. It does not mean, because that's another thing that I've heard many a resident and student say, hey, wait a minute, now that I have, let's pick on Epic for a moment, which is our system as well, an app that essentially opens me up to 24/7 access, am I expected to be an interpersonal source of continuity at 3 a.m. every night of the week? No.
Yeah.
We have to set up rational systems where continuity is a virtue, it's delivered in teams, it's measured as such, and we're building in boundaries that don't use it accidentally to worsen, burnout. So.
Yeah, I think that is part of our jobs as preceptors and educators, is what are those boundaries. I also see some discontinuity even in the way that a day is structured. So my residents will sometimes be coming straight from the ICU to clinic. Other times they're in an ambulatory block, and I think they can appreciate all of the wonderful things about primary care more when they just have that brain space and that focus on that area. So we just have a few minutes left. There's one other question I wanted to ask the group, and then I don't know if we can take questions more broadly or if anyone has any, but I'll ask this last question and then see if there's anything from the audience. We've focused our conversation on interpersonal continuity. There's also this idea of informational continuity, right? There's that we want to understand information coming from different settings. In our role as coordinators across these settings and providers, it's important for us to understand what's happening to our patients writ large. That's becoming harder and harder as just the amount of information grows, and we still don't have the interoperability to actually be able to see it, let alone parse it in a meaningful way. I'm always still struck when patients were like, "Oh, that must be in there somewhere." And I agree with them, and yet the ability for me to quickly access that information, make sense of it in a way that's useful at that visit is often limited. So I wondered if we could speak a bit to that idea of informational continuity. What are, again, some threats and opportunities that you see?
Yeah, for us, it's really challenging because we're an independent group. We're physician-owned. And so we aren't on the instance of Epic that the local hospitals are. And in fact, we're on eClinicalWorks, so it's French and German. And so we've had to have and build multiple interfaces to try to get that information. And not just accessing it, but getting it timely. Because again, as being responsible not just for their experience, but financially for our patients throughout the system, we want to know in real time, as close to real time as possible, what's going on with them. So we actually created a transitions of care group of RNs that's their only job, is to track our patients through the system. We have a lot of data that shows that the sooner a patient that's discharged from a facility such as hospital or SNF sees their primary care team, the readmission rate goes down. And so the clock is ticking. And so we've really made some great strides in that. We have improved we're into the 20% range or so of our hospital discharges being seen back within 2 days. So, and we've seen readmission rates start to drop, but it's been a huge lift. I mean, that's not a cheap way to go about it when you're paying half a dozen nurses to track 70,000 patients across 8 counties and 3 hospital systems and a couple hundred SNFs. And so there's got to be a better way of getting that continuity of information at some point. Right now, we're still parsing it together, but I think it's a combination of human, AI, IT, and trying to bring all that together.
Yeah. And Brady, just to follow up on that, you were describing this to me earlier, so I'd like you to share it here. So the nurses are literally logging on to...
I think we have 6 different interfaces right now, and my personal admin assistant was actually pulled in to actually physically call the SNFs to see if our patients were still there. So that's one of her to-dos besides managing me, which is a full-time job, but is to actually run the list of our SNF patients and see where they still are.
Yeah.
And so we can try to catch them on discharges or readmissions and things. It's become a full-on team sport.
Brady said it well. We have a long way to go. I mean, it's a bit Dickensian. These are the best of times. We have gotten further along a path towards something like meaningful use and interoperability than we were 10 years ago. But in our ABFM survey partnership with the Office of the National Coordinator for HIT, we can pretty clearly say that very limited number of folks are very satisfied with their electronic health records, with interoperability, so forth and so on. We wouldn't tolerate that in other sectors and even within our own health system. In our surgeries, for example. Yeah. What I would note, to turn it back to optimism, is, it's amazing to think, and we're making a bet, an ABFM bet on artificial intelligence as a positive in an age of large language models, about where the frustration that I have when my patient, I have to say, yes, we've had a 15-year relationship, but we switched EHRs in 2020, and all the information before them is in a giant jumble, and I'm lucky if I can find it. It's amazing to think what large language models can do to begin to clean up the mess. Even as interoperability may be a long, slow, road that requires a lot of things that we as clinicians can't control. It's amazing to think what we can find in our records. natural language processing opens doors to understanding what's happening in notes for our teammates in ways that we haven't had before.
Yeah.
It does begin to offer the possibility that, that these technologies will reinforce, and even back to making your technology your teammate, will enhance our continuity, and that if we can use in an iterative fashion those processes to make our notes better, more efficient, stronger, that when our patients need something, they come to us, they come to their technology that we've helped them build, and they find the things they need when they want them. So I'm optimistic. I think this will continue to improve.